When a physician makes a decision to treat a patient with first-line therapy, multiple factors come into play. Most commonly, patients are treated with either immunotherapy alone. Currently, rituximab is the only antibody approved for that indication, or a combination of immunotherapy and chemotherapy. Similarly to follicular lymphoma, this decision is somewhat subjective. The expectation most commonly is that patients with relatively low bulk disease will do well with immunotherapy alone, and the relatively rare patient with bulky disease needs combined chemoimmunotherapy. Unlike follicular lymphoma, we really have a dearth of randomized first-line trials, so sometimes that decision is more subjective perhaps and less scientific than we would like, but this is what we have in terms of data. Looking at rituximab bendamustine versus R-CHOP, we do have a randomized trial, though it wasn't dedicated specifically to marginal zone lymphoma patients. That trial, the STILL trial, compared predominantly follicular lymphoma patients with stage 3 and 4 disease and included other subtypes. So the marginal zone lymphoma patients were really a small cohort. We can infer from the larger results of the trial, however, that R-bendamustine compared favorably with R-CHOP. In addition, the side effect profile of R-CHOP far outstrips negatively the rituximab bendamustine. There is a second trial, which is a little problematic, called the BRIGHT trial, and that trial raised some concerns about rituximab bendamustine's toxicity profile. However, most medical oncologists currently prefer rituximab bendamustine over R-CHOP. The options for follicular lymphoma compared with the options for marginal zone lymphoma in first-line therapy are currently pretty much similar. What we don't know, for example, is whether other drugs that might be currently used in second-line therapy, for example, ibrutinib, would compare favorably in the first-line setting, and this is a trial that we hope to begin this year.